everyone. Welcome to another episode of Health with Dr. Yvette Maseka. This is a podcast that aims to correct myths around health. Today, we're going to talk about non-communicable diseases. So non-communicable diseases are diseases that are not contagious. So you can't pass it on from one person to another. So we're talking about diseases like heart disease. We're talking about your strokes, your cancers. When you have this disease, it's just yours. You can't pass it on. And today I'm joined by my friend and colleague, Dr. Blessings Kasenge. Dr. Blessings, welcome.
Thank you so much for inviting me, Dr. Yvette. I'm extremely excited to be here. And of course, I'm looking forward to the show.
Thank you. We should be saying thank you for being here. It's such a pleasure. So Dr. Kasenge works for CIDRS. What do you do at CIDRS?
So I'm a clinical research mentor at CIDRS, which is the Center for Infectious Disease Research in Zambia. So I'm currently working on a project called TaskPen. So TaskPen, the focus is management of cardiometabolic NCDs, particularly hypertension, diabetes, and dyslipidemias in people living with HIV.
Okay.
Yeah.
Ooh, those were some big words. But thank you for breaking them down. So I want the viewers and the listeners to know these non-communicable diseases. How common are they in Zambia?
So NCDs are actually quite common. I think when we first look at the global perspective itself, we realize that NCDs are a leading cause of death.
They are, yes.
And the World Health Organization actually estimates that by 2030, they'll be the leading cause of death globally. So they're becoming a very serious issue. And if you actually look at the fact that we're a low and middle income country, these diseases are actually increasing in our setting, particularly for various reasons, I think, which we're going to get into as we get into the conversation.
Yeah. And there's a myth about these non-communicable diseases, which are NCDs. There's a myth that these are diseases of the rich. So I'm sure someone out there is wondering, like, for low and middle income countries, how does that happen? So I think what we need to talk about is what's causing these NCDs, and are we seeing an increase of these hypertensions and heart diseases in young people? I remember the soccer player who came back because they found that he had
Enoch Mwepu.
He's Enoch Mwepu.
Yeah.
Yes. So are they becoming common among young people because he was a relatively young guy to have such a heart condition?
Yeah, so I think we'd also have to first look at the risk factors of these NCDs, and the reason why they're actually even becoming common, even in young people, is because of the risk factors themselves. So risk factors like alcohol abuse. So with so many young people these days that are actually taking a lot of alcohol.
True.
So that's also a major risk factor in terms of developing the NCDs.
Yeah.
And we also have tobacco use. Tobacco smoking, which is quite common also among young people, which I know we're also going to get into when we talk about tobacco itself. Physical inactivity. So this is also very common among young people.
That's
when
true.
you actually even just wake up at 05, you find some old people jogging here and there.
Yeah.
Young people are sleeping. They wake up at 10 hours.
That's true. And also I've noticed people are more on their phones. They are less active. Even children. You give a child a phone to play with, you give your child a tablet to play with. They're not going out to play things like soccer. They're not doing outdoor activities. They'd rather just stay in and play games.
Yeah.
Also, adults are also playing a lot of games.
Yes, exactly.
Sitting for a long time. Eating junk foods.
Yes.
Like, eating these crisps and whatnot.
Yeah.
They're called crisps.
Crisps.
Yeah. And I think that's really contributing to why we're seeing a lot of this. So when it comes to tobacco use, I'm very interested. There's this belief that shisha is safer than a cigarette.
That's a false belief.
Okay.
Yeah, that's a false belief.
What are the effects of shisha? I came across something that was predicting that in the next 20 years, we're going to see a lot of women with lung cancer because now shisha has become
it's taken over.
The in thing, especially with the young ladies, because it's a cool thing to do. Yeah. So any other effects that we're expecting from things like shisha?
Yeah, so when you look at tobacco itself, I think breaking it down, like this is really one of my passions because I think we've really seen an increase in the use of tobacco, especially among young people. And WHO actually says that by 2025, we're going to have 300,000 new smokers of tobacco. And most of these will actually be young people. So 2025 is like next year. So we're going to have like 300,000 new tobacco smokers.
That's
so
a lot.
It's been increasing, especially here in low and middle income countries for various reasons. One of the reasons could actually be that it's easily accessible and it's more affordable. Like shisha, for example, you can easily walk into any club and request to say, I want shisha, and they'll give you shisha. So when you compare shisha itself to the cigarettes, what research has actually shown is that one session of shisha is equivalent to 100 cigarettes.
Yeah.
So it means when you do one round of shisha, you've done 100 cigarettes. I know obviously people that do shisha like get to be in groups, but then still we find that in probably a session of shisha, probably you've even done 20 cigarettes, maybe 20, or 5 of you. So you've done like that whole thing, which is equivalent to 100 cigarettes. So shisha itself is actually very harmful. And even when we talk about tobacco, we like to really get into explaining what are some of the ingredients that are in tobacco, which I think most people don't know about.
Yeah.
For example, nicotine itself, which is very addictive.
Yes, it
Most
is.
people don't know about that it's one of the contents
Uh-huh.
of tobacco. So people just find that they're addicted to it, but nicotine itself is a very huge component. And then we've also got carbon monoxide. So carbon monoxide itself is a poisonous gas.
Yeah.
And it usually competes with oxygen for hemoglobin. So it means that it actually depletes oxygen in the tissues. So it's quite poisonous. Then we also have tar. So tar is the thing that they use to make tarmacs. Yeah. So tar is also a component of tobacco.
Yes.
And this actually is carcinogenic, meaning that it can cause cancer. So this is where the lung cancer comes in. Yeah. So these three are actually the main components. Of course, there are over 7,000 chemicals in tobacco when it's burnt, but these three are actually the ones that are most prominent.
Yeah. Then there's this new thing that people are now doing, what they're calling vaping.
Yeah.
So I mean, I read a little on it.
Yeah.
It's where you're using an electronic
Cigarette,
it's an electronic cigarette that heats up, and basically the word vaping is coming from the vapor that's produced when this thing is heated up. So people say I'm not smoking, I'm vaping. So is vaping safer than smoking?
So firstly, I love to say that there's no amount of tobacco that's safe. So it means that every form of tobacco, regardless of its quantity, is not safe. So vaping, which of course is the use of e-cigarettes, when you compare it to the actual cigarette, you find that vaping or e-cigarettes don't have carbon monoxide and also don't have tar. But what they have is nicotine. So nicotine itself is extremely addictive. So these are actually readily available also on the market. So you find that here's a young child. He starts vaping at a very young age. He's going to become addicted because of the nicotine in the e-cigarettes. Then later on in life, he may actually resort to going to the actual cigarette itself. So actually, it's also not safe, although it's slightly safer than the actual cigarettes. But as I said, there's no quantity of tobacco that's actually safe.
You know, these people are vaping. You can actually wonder if they're even breathing in any oxygen. Because it's just...
Yeah.
Are you even breathing oxygen?
And they're flavored also.
Okay, yeah, they're flavored, which makes it a little more interesting.
Yeah.
So what NCDs are common in Zambia? Which NCDs are we seeing a lot, especially in the youth?
Yeah, so we're seeing a lot of hypertension in the young people. This is simply because if you look at all the risk factors of NCDs that we talked about, tobacco, alcohol, physical inactivity, diet as well. So all these could actually cause hypertension. So hypertension has become very common here in Zambia, and I can say it's really among the most common of the NCDs. But we also have diabetes, which is also quite common. Then we also have dyslipidemias, which are, of course, coming as a result of having too much cholesterol within your blood. So this is also coming from the diet that we're actually adopting here in Zambia. So I would say these are actually the most common. But we also have other types of NCDs, for example, asthma, respiratory ones, chronic obstructive pulmonary disease, which as a result of smoking. So these are also seen within our setting, and of course the cancers.
Okay. In your project, Have you told us what your project is about?
Not yet.
Okay. Can you tell us more about your project?
Okay. Yeah, so as I said, under the TASPEN project, so what we're doing is we're managing cardiometabolic. So cardio simply coming from heart. So we're talking about hypertension and everything related to the heart.
Yes.
Metabolic, we're talking about metabolic issues, for example, diabetes. So we're looking at cardiometabolic conditions in people living with HIV,
Yes.
with a main focus on integration and creating a one-stop shop. And what I mean by this is that, for people living with HIV, they are more at risk of developing complications from NCDs compared to the general population. So that's why we zeroed into those that are living with HIV and ensuring that in these ART clinics, for example, you know how HIV clients, for example, they develop an NCD, they have to be referred to, let's say, OPD or to another hospital for the management of that. But we're looking at how best we can ensure that they are benefiting from all the services in one roof, which is like a one-stop shop, meaning they're screened for hypertension, for diabetes in the same place. There are also drugs for hypertension, diabetes in the same place, so that as they are being managed for the HIV, they're also being managed for the NCDs. And I think sometimes as clinicians, we become culprits in that we tend to just focus on one thing.
That's true.
Yeah. And I remember the time that I was doing some voluntary internship at National Heart Hospital. We actually had a patient who was hypertensive and diabetic and was also a non-smoker. So every time we're doing the rounds, we'll talk about the hypertension, the diabetes, but this is a guy who would, after the round, immediately goes to smoke. So that is something we paid like a blind eye to. Like, we don't care about your smoking. We care more about your hypertension and your diabetes. And it's also the same with HIV. We focus so much on what's your viral load, what's your CD4 count, but we don't really get into finding out like what else do you have apart from the HIV.
Yeah.
So that is what our project is focusing on.
So my consultant always tells me to look at a patient as a whole.
Yes.
Instead of just picking out because you're specialized in this, so you pick out this. I saw this joke. Someone posted this joke on the doctors forum, and the joke was there was someone who was vomiting, and an orthopedic surgeon, these are people who deal with bones. He was passing, then someone stopped him, said, "There's someone vomiting," and he asked a question to say, "Are they vomiting bones?" So
no, I don't care.
Yeah, if not. So my consultant is always telling us to look at a patient as a whole. Talk to the patient. What are they going through? Sometimes even things at home can contribute to what a patient is actually going through. So apart from what we've talked about, what would be your advice to the youth in preventing these NCDs?
So my main advice to the youth would be one thing I've noticed about youth, especially not only in Zambia but worldwide, is that I think our biggest problems are alcohol, tobacco. These are our biggest issues. So when it comes to alcohol, we must really start telling young people to really reduce when it comes to alcohol. I think there's actually a recommended amount of alcohol that you're supposed to take. So I think it's important that we even highlight just the quantity that young people should be able to take, at least, because there's so much alcohol abuse out there, and this alcohol abuse is what is leading to developing some of these NCDs. And then also you would note that injuries are also part of NCDs. Injuries are also classified under NCDs. So when someone takes alcohol, probably they'll be in a road traffic accident, probably beaten up, they get injured. That's an NCD as well.
Because you can't transfer it to someone else.
Transfer it to someone. So injuries are also quite common, the common type of NCD, and I think they really stem from alcohol abuse mostly. And then even when it comes to the aspect of tobacco, this is something that young people must stay away from, because this could actually have implications later on in their lives. You may start smoking today, but you may only develop lung cancer, let's say, at the age of 50. And you like put yourself in a very difficult position. Of course, you know how expensive treatment is for these cancers. So let's ensure that we're very wise in the decisions we're making today, because this could actually in turn affect our future. So that would be my main advice to young people.
Zambia is not a smoking nation. When you go to other countries, you see people on the street, literally everyone is, with a cigarette. But we're seeing this smoking
Yeah.
increasing.
Yeah, it's actually
Especially,
increasing.
especially among us.
Mm-hmm.
As
Yeah,
the
it's
youth.
actually increasing. I think I gave you the statistic. It's actually
Yeah.
increasing. And I think even when it comes to another aspect of tobacco itself,
Mm-hmm.
so globally, there are like 8 million people that die out of tobacco
That's a
smoking.
lot.
But 1.2 of these actually die from secondhand smoking.
Yeah.
So it means that you might not be smoking, but just by you being found in an environment where people are smoking, you're actually affected. So when
yeah.
it comes to tobacco, no one is really free at all. Because sometimes here, like you just basically go on a normal chill, maybe just at a shopping mall,
And
but
someone
then you
is
find people are smoking and you're also affected.
Yeah. This is why I really appreciate those places, restaurants and other bars
Yeah.
where there's a no smoking policy.
No smoking policy.
Yeah, where they ask you to go outside
Mhm.
if you want to smoke because secondhand smoking is a problem.
Yeah.
And in our communities, especially the compounds, you find that the father smokes
Mhm.
and the father will be smoking in the house
Mhm.
with their children.
Yeah.
You find some of them even live in a one room.
Yeah, one room.
Yeah, one roomed house, and they're there smoking.
Mhm.
And they don't know that they're putting their children at risk. So if there's anyone out there listening to us, if you smoke, please do it away from people. Don't expose people because these things, they may have effect on your children or other people in future. Yeah. And is obesity a problem in Zambia?
Obesity is becoming a problem in Zambia. Of course, it can be compared to the Western countries. I think there is more obesity there in terms of prevalence, but we're also seeing an increase in the prevalence of obesity in Zambia for those reasons that I've mentioned. For example, I can give you a very practical example. Like if we go back maybe even 15 years ago, carpenter was cheaper than everything else.
Yeah.
You get right. So people will be buying carpenter, ifishimu, and all these things. But suddenly tables have changed. Like fish is actually very expensive when you compare it with chicken.
Yeah.
And even slightly to some extent beef as well. So you find that people are adopting more. The diets have changed because of the affordability of the food itself. Even other types of food. For example, you can easily grab chicken and chips for 40 kwacha.
Yeah,
More or less.
That's true.
Yeah, so it has become quite affordable. So because of that, people are actually preferring to just buy food and not cook. Because like for 40 kwacha, you can like be satisfied. Why should you start cooking for an hour and all that? So because of that, it's also becoming a very huge problem here in Zambia as well.
Yeah, but I feel that everyone has a role to play when it comes to NCDs. I think the real problem is that we're also not diagnosing these patients early. So you find that when we find that someone is hypertensive, maybe at the point we actually diagnose them with hypertension, they already have heart complications.
Yeah.
Some people just drop at home. They have a stroke. Then they come to the hospital. You ask them, does this person have any hypertension? Do they have any diabetes? And they have no idea because health-seeking behavior in Zambia is very poor.
Very poor.
Yeah. And also because, some people are coming from remote places where it's very hard for them to access health facilities. Some of them do want to come to the hospital, but they can't access the health facility.
Yeah.
So I think even the government has a role to play. We need better transport systems. We need more healthcare centers. I mean, there's obviously an improvement. Looking back, 10 years ago, there's a very big change now. Yeah. And we also need to educate people more. When I started this making videos and whatnot, I really didn't think people are going to watch because in my head, Zambians prefer entertainment to
something fun.
Yeah. So I hope someone out there is listening and learning something.
Yeah.
And
I think just riding also on your point, sorry to cut you short.
It's okay.
The aspect of screening for me, I think is the one that really hurts me so much because even just a basic blood pressure reading, I think at least that's the least we can do, especially even at facility level. That's one thing that I've really even gotten to see with the project I'm currently working on, was when we went to these facilities, we find that there's no BP machine,
Yeah.
like random blood sugar. Like it's actually a privilege for someone to even know their
Their blood sugar.
their blood sugar. Like others will tell you to say, in my whole life, this is the first time that I'm actually being tested
For sugar.
For sugar. So
Yeah.
like, that itself should not be happening in our country. And even talking about NCDs, like this should be the starting point. Let's provide the basic equipment. Everyone who goes to the hospital should have a privilege, at least, of having the blood pressure measured, having the blood sugar checked. So what we're actually doing with our project is that we even provided a small machine which we're calling an ichroma machine. So this machine is able to test HbA1c, it's able to test LDL as well. So it means that HbA1c is quite costly.
Yeah.
But if we can provide,
for those who don't know what HbA1c is, this is the glycated hemoglobin.
Yeah.
So this is a test that shows how well your sugar has been controlled in the past. Is it past 3 months? Yeah. In the past 3 months. So that's what he's talking about.
Yeah. Thank you for breaking that down. Yeah. So we're providing this test. Like, we need to ensure that we take these health services as close as possible to the communities. I think that's what part of universal health coverage is. That, of course, for people to be working long distances, one of the ways we could actually keep that is by taking these services as close to them as possible. And that ensures that we strengthen primary health care, means clinics, level 1 hospitals where people are easily walked to. Obviously, someone will not come immediately to UTH unless they're staying close to UTH, but let's ensure that we strengthen that first level part of health itself.
Yeah, that's true. I want to get your opinion on something else. Are we seeing more cancers in Zambia? Or are we diagnosing them more?
That's a tricky question. So it's a bit of both. I think it's a kind of a two-edged sword on my end, because yes, because of these lifestyle behaviors and poor health-seeking behaviors, I believe that the prevalence of cancer is actually increasing itself. I think when you talk about cervical cancer, when you talk about lung cancer due to the smoking itself, so I find that we're actually seeing most of these. But again, with the cancers, what we're also seeing is that most of the patients that actually come end stage, the last stage now, when there's literally almost nothing
you can do.
Much that you can do. So even in our diagnosis, I don't think we are really doing so much in terms of diagnosing and sensitization, because some of these cancers are actually born with them. I think is it Angelina Jolie, like, who went and tested for the BRCA gene,
and then
the breast removed. And I can just imagine, like, how many people in Zambia could actually know well in advance to say, I've got this gene for breast cancer, let me just have my breast cut off so that I don't get to have breast cancer ever in my life.
Yeah, but we're not there yet.
We're
not there yet. We're getting there.
Yeah.
But for cancer, it really saddens me, because people really come when there's literally nothing we can do. The only thing that we can do is just make them comfortable until they just, and
that's why pass on. The emphasis also should be that, because cancer begins even as basic as a fever, just lose some weight,
or it's sweating a lot at night,
and sometimes we get to ignore some of these simple symptoms, but this is actually cancer starting. That's why, regardless of how small the symptom would be, I think let's always go to the hospital.
I once had a patient, he came with a tumor in his abdomen, and I was asking him that, was your body getting hot? And he's like, yes. Maziba Bonj. I asked him, were you sweating at night? He thought I was just, prophesying, like, oh, you were experiencing this. And he was so amazed. So amazed. Like, how did you know? I haven't even complained about this, but how did you know?
How did you know?
Yeah. So there are those little things that people really ignore that could be signs of cancer. So I had a few cards for you.
Okay.
Yeah. So these cards are myths. Where did I put them? These cards are myths that people say when it comes to diabetes.
Yeah.
I know diabetes is also becoming quite common.
It is.
And NCDs, naturally NCDs usually affect people as they grow older, but now we're also seeing them in young people. Yes. So these are some cards.
All right.
You can just read them out
Okay.
and tell us your answer.
In any particular order? Or just start with
You
any?
can start with any.
All right. So diabetes leads to amputation.
Mm-hmm.
So this is not true. Yeah. So what actually leads to amputation, I would say, are complications of diabetes.
Yeah.
Yeah. So it means that you can have diabetes, but if it's properly controlled, no need of actually amputating your leg.
That's
Yeah.
true.
So let's ensure that we avoid or prevent diabetes from getting to the end stage, which are the complications, by ensuring that we're adhering to our medications, and of course, even by putting in place these lifestyle measures, reducing smoking, alcohol, maintaining a balanced, proper diet.
Mm-hmm. So before we move on to the next one, what are some of the things that people can look out for? What are some of the signs, symptoms that someone can look out for?
Yeah, so for diabetes, one thing that you need to look out for is increased urination.
Yeah.
Once you notice that there's a change in your urine frequency, or even in the amount or the quantity of the urine itself, something you need to look forward to. Then also, if you have increased thirst, like if you're always feeling thirsty despite you taking fluids, that is also something you need to look towards or look out for. Increased appetite as well.
But you're not gaining weight.
Yeah.
You're eating a lot, but you're not gaining weight.
But you're not gaining weight.
Yeah.
So that is something that they must also look out for. And general body weakness.
Yeah.
Body malaise, like just general feeling of weakness. I think that is something that we must also look forward.
Yeah.
Look at. Yeah. When it comes to diabetes. So diabetic people cannot do sports. So this is false. Again.
I don't even know where that came from.
Yeah, no, actually I think the logic maybe is that usually when you develop a wound and you have diabetes, it takes time to actually heal.
Oh yeah, because we're always advising them to wear closed shoes.
Yeah, to wear closed shoes so that you don't get injured, because these wounds can actually take time to actually heal and can be very bad. So that's why, of course, you can do sports, but just ensure that, of course, you're wearing closed shoes and you're safe as well as you're doing these sports, preventing yourself from getting injured. So simple jogging can actually work out for. I think what's recommended is actually brisk walking. So just brisk walking. Yeah, I think those are actually safe.
Okay.
Diabetes leads to blindness. So this is not true as well. It's the complications of diabetes that would actually lead to blindness. So once diabetes is properly controlled, well managed, adhering to medications and everything that we've talked about, you will not actually even become blind. Yeah, but what will lead to blindness is if you've got diabetes, you're not taking your medications, eating anything that is given to you, then definitely you may actually lead to yourself becoming blind. Yeah, so that's a complication. Diabetes only affects adults. So again, this is not true. It doesn't only affect adults. It also affects young people. Because diabetes, there's type 1 diabetes and type 2 diabetes. So type 1 diabetes is where you are lacking insulin. So insulin is a hormone that is in your body, and it just helps convert the glucose into it. It basically ensures that the glucose itself is taken up by the cells. Yeah, in simple terms.
Yeah, because glucose is in the blood.
Yes.
So your cells are supposed. Insulin is like a gate opener.
Yes. Gate opener.
So like it opens the door for the glucose to move from your blood to your cells. Yeah. So if you don't have insulin, it means the glucose is just going to remain in the blood. So meaning that your sugar level will be high. That's the logic behind diabetes. Yeah. And then type 2.
Just on the type 1, so the insulin, it's made like in the pancreas.
Yeah.
So the pancreas is like an organ in the body. That's where like the insulin is made. So we find that even for young people that develop pancreatitis, where the pancreas is completely damaged, so commonly binge drinking.
Yes. Alcohol.
Yes, alcohol. You go out for a night and you want to drink over 10 bottles at a go. You damage your pancreas, and your pancreas will not be able to produce the insulin, and you develop diabetes. Yeah, so we see that this can also be found in young people.
Yes.
Then
I've actually seen that. You know, I had a patient. The patient came in with severe pain here, and so we thought it was pancreatitis. So we asked him, "Do you drink?" And he was in pain, and he's like, we seen mama. And the wife was like, "Imwebs kama zona." Mwandini moba bakuma moba. And we checked his sugar levels.
Mhm.
Sugar levels were high.
Yeah.
Checked his enzymes. His enzymes are also deranged.
Yeah.
And he had he developed diabetes.
Mhm.
We managed him for the pancreatitis, but his sugars were still high. So we managed him for diabetes. We sent him to the diabetic clinic.
Mhm.
And that's because of alcohol. He was, I think, 32.
Oh, quite young.
Yeah, quite young. So alcohol, guys.
Yeah, the classic example that you've
Yeah,
given.
classic.
Yeah. And then type 2, of course, is one that's more lifestyle based. So even young people can have type 2 diabetes as well.
Yeah.
But of course, we see that it's more common in adults.
So in type 2, this is where you're producing insulin,
Mhm.
but the door is just locked. Your cells just can't take it up because your receptors are not sensitive to the insulin. So
Yeah.
type 1, you're not producing insulin. Type 2, your receptors are not sensitive to the insulin. That's the difference.
Yeah.
So
that's yeah.
So children can also have diabetes. They're actually quite a lot. You'd be shocked.
Yeah, quite a lot. Yeah, and pregnancy as well, gestational.
Oh yeah.
diabetes.
Yeah, pregnancy.
Yeah.
Yeah, unfortunately, some people actually it just goes on to become diabetes.
Yeah, exactly. It starts in pregnancy, and it's the same also with hypertension.
Yeah.
It starts in pregnancy and
just goes on.
Wow,
that's sad.
Yeah.
I wouldn't imagine myself getting pregnant and just from there, you're okay, you get pregnant, you have hypertension or diabetes, and then after delivery, you think everything will go back to normal, but
it just continues.
It just continues and you're on these lifelong drugs.
Yeah.
It's quite sad.
So we'll tackle this one, right?
Yeah.
Diabetic people cannot eat sugar. So not really.
Yeah.
So maybe when we talk about sugars, there are different types of sugars. So there are natural sugars. So natural sugars are found in fruits and vegetables. So these are actually what we actually encourage diabetic people to actually eat more fruits, eat more vegetables, because there are more natural sugars. And then there are more refined sugars that are found in other foods. Yeah, commonly here in Zambia, breakfast, meal.
Yeah.
Like that's like very refined sugars, very refined carbohydrates. And so we normally discourage diabetics to eat those types of foods, especially on a daily basis. Yeah, so I think sugars are there, but just a matter of prioritizing the types of sugars that you're taking. Natural sugars are better. But
also remember that there are some times when diabetic people also go in a state of low blood sugar.
Yeah.
So true. Such a scenario, you give them sugar. So sometimes you even tell them, they actually know the signs. Like you tell them, like you notice you start sweating, you're going to have you're going to start tremors, like you'll be shivering, you have lightheadedness, you feel dizzy, like those signs when you're really hungry. So most of the diabetics are actually educated on that. So we even encourage them to just have like a Fanta or a Coca-Cola. That even really helps. Yeah, because in as much as you have diabetes, your sugar being high will kill you. Even your sugar being low will kill you.
Yeah.
Actually, I think even your sugar being low will kill you faster than your sugar being high.
Will actually kill you faster.
Yeah. So you can take sugar in some scenarios like that, but also just keep it healthy.
Ensuring that there's a diabetic diet. I think they do get cancelled also on the type of food they're supposed to eat.
Yeah.
Less on the carbohydrates. If it's like a 3 plate of nshima, like a small part is what the nshima is supposed to be.
Yeah.
And the vegetable should be on the bigger part. And like where
it's the other way around.
It's what common in Zambia, where you eat more nshima and less relish.
Yes,
like
actually.
When this guy is having 4 lamps.
Some people were saying that this is why we are stunted in Zambia, because we don't eat a lot of protein. Yeah. We eat more nshima.
Yeah, that's true.
Than proteins and other things.
Yeah, that's very true. Okay, that's one. Only affects obese or fat people. So again, this is not true.
But are they at increased risk of getting?
Yeah. So what happens is with obesity, you actually have more insulin resistance. The more obese you are, the more you're likely to have insulin resistance. Yeah. So you find that for those that are mostly obese, most of them get to develop diabetes.
Yeah.
So which is why even with eating too much sugar, you eat too much sugar, this sugar, the excess is converted to fats.
Yeah.
Yeah. And these fats are eventually now what get to build up in your body, and later when you develop this insulin resistance. So you might not get necessarily diabetes from eating too much sugar, but of course this too much sugar gets converted into fat, become obese, then it leads you to developing diabetes.
Oh, okay, that makes sense.
So that's basically what happens. So it can affect anyone. You can be slim, you can still have diabetes. I think we even talked about type 1. You can be very slim.
Yeah, type 1 are actually quite slim. Yeah. So are the myths done?
Diabetes leads to amputation. Yeah, we've done. They're done.
Oh, they're dead. That's so sad. I thought there were more.
We're done.
Okay. So is there anything else that you would like to tell our listeners and viewers? Maybe there's something I've forgotten.
I think pretty much we have covered everything when it comes to NCDs. Just an emphasis that these are actually becoming quite common, especially in our setting. And that's why we need to ensure that we are doing the right things. Too much of everything is bad. Too much of alcohol, too much of whatever eating, too much of everything can actually lead you to developing a particular condition, mostly like the NCDs we've mentioned about. But of course, the most important point of emphasis is let's ensure that we seek help whenever we have any symptoms, especially for hypertension. These are actually silent killers. So most people sometimes just hear that he just fell down, he was okay.
Yeah.
Next minute, he just collapsed, and that's how he died. So it's because mostly some of them might have developed hypertension, then later they died. Some of them, their BP shot, developed a stroke, went to the hospital, they didn't make it. So we see some of these things on a daily basis in our hospitals. So it's important that we're always taking precautions, always ensuring that we are visiting hospitals, and of course, Dr. Yvette, regular medical checkups. I don't know why exactly I don't like. I think the assumption is always that you go to the hospital then you're sick.
You're sick, yeah.
But regular medical checkups, just to check your blood pressure, check your blood sugar as well, know what levels they are, just have an idea basically of how your body is functioning. That itself goes a long way in you managing anything that can come your way.
That's true. And also, if you have diabetes or hypertension, please be consistent with taking your medications. Be adherent with your medication, because these complications they're quite detrimental, because hypertension will lead to your heart being damaged. It may lead to blindness. It can damage your kidneys. Same with diabetes. So please be adherent. I hear some people saying that I only take hypertension medication nikamvela ya kwela.
Exactly.
And you ask them, like, do you have a BP machine at home? And they're like, weni mazimvela chabati ati BP ya kwela. I'm like, no. That's not how BP works, guys. Yeah. So take your medication every day. It's not that if you take your medication and you notice that your BP is lower, then
you have to stop.
Then you're cured. No. Those drugs are for life. So guys, save your life. Be adherent to your medication. So thank you so much for joining us, Dr. Kasenge. We've learned so much from you.
Thank you so much for having
me,
Dr. Yvette.
I really love the work that you're doing. There's a lot of discrimination around HIV people. I mean, it's improved, but it's still there. So if we can integrate management of NCDs and management of HIV, that's really great, because it avoids them moving from one hospital to another, because that can take the whole day.
Yeah, definitely. Moving from this ward to
this ward. So if it can be done in one place, that's
one
really
thing I've
awesome.
learned as well from you today is that let's always look at our patients as a whole.
Yeah.
I think this goes out to the clinicians, especially to get to attend. But just not pay a blind eye to a particular aspect and only focus if it's hypertension, you focus just hypertension.
Yeah.
But let's look at where our patients are coming from. Let's ensure that we advise them correctly as well, putting everything into perspective.
Yeah, that's really true. So this was Health with Dr. Yvette Maseka, where we correct myths around health. If you have a comment, if you want us to talk about something, if you want to remain anonymous, please visit my website. It's Health with Dr. Yvette. And if you're comfortable, you can just leave your topic in the comments. So this was Health with Dr. Yvette. Bye-bye.